Today I'm going to talk about how to manage difficult bile duct stone. So I have no financial disclosure. We're going to start the talk with the introduction. Then we will talk briefly about how to approach patient with suspected bile duct stone. And then we'll talk about the risk factor of difficult or what we call complicated bile duct stone. And we'll conclude with the endoscopic technique about how to manage these bile duct stones. So about 7 to 12% of patients with cholelithiasis have bile duct stone, and about 10 to 15% of them are complicated stones. As all of you know, ERCP is the procedure of choice for removing those stones. ERCP was first reported actually not by the gastroenterologist, even though we take pride of doing those procedures. The first reported ERCP was in 1956 by two radiologists from Harvard School of Medicine, Simon and Ribanov. The ERCP has been shifted from being a diagnostic tool to be a therapeutic tool. So this is mainly because of the risk of complication. As you can see, the risk of pancreatitis can be actually less than 5%, but there is more sensitive test and less invasive. And this is why we try to find a better cost-effective approach to diagnose CBD stone. So how to approach a patient with a suspected bile duct stone? The ASGE have a very clear and nice guideline which try to focus on how to approach those patients with a suspected cholelithiasis. There is very strong predictors, like if you see a CBD stone in ultrasound, or if you have a clinical ascending cholangitis, or if the bilirubin is more than 4. Or if you have two strong predictors, what we call dilated CBD more than 6 millimeter in the gallbladder and site, in addition to a bilirubin level between 1.8 or 4. Those patients, actually, you can go straight for an ERCP, and there is no need for further diagnostic testing. Everything else, you probably need to do more testing. That's going to be based on availability and your clinical judgment. You can see here the MRCP and the EUS are less invasive, but very sensitive in detecting bile duct stones. Or if the patient's going to go for cholecystectomy, then you can ask your surgeon to do an IOC. This is a very good cost-effective tool to be used by the gastroenterologist to determine whether they can go for an ERCP or if they need further workup. So how to approach a patient with a CBD stone? So the first thing you need to do is you need to assess your bile duct anatomy. It is very important for you to spend some time, review the image to see if the patient has a normal bile duct or if there is any risk factor for complicated bile duct stone, to make sure that you have, first of all, the equipment you need, and second, you have the time and the expertise to take care of those stones and remove them successfully. The second step is you need to cannulate the bile duct. This sometimes can be time consuming, and some bile ducts are really difficult to cannulate. This is going to be another talk for another day, because there is too many different techniques you can use to cannulate the bile duct. And then you need to create an exit path. That exit path should be, first of all, should be sufficient to remove the stone and safe. And then you need to decide whether you need to use a lithotripsy, and if you need to use a lithotripsy, what kind of lithotripsy you need to use. And then you finish your stone extraction by a balloon or a basket, and then you watch for any possible complication which can develop especially immediately, and some of those can be managed endoscopically before the end of your procedure. And finally, if you cannot remove the stone, it's okay to put a stent and bring them for another day so you can remove the stone later on. So what are the risk factors for difficult bile duct stone? Multiple studies have been performed, and And there is, of course, there is some patient factors, which I'm not going to talk about, like age, comorbidities, but there is some stone factors and there is some anatomical factors. The stone factors are if you have a large stone, more than 1 centimeter, or you have multiple stones, more than 3, or you have, or based on the location of the stone, if the stone is proximal and you have a stricture, or you have multiple impacted stones, those are considered to be difficult bile duct stones, and it will require more time and effort to be removed. Also, if the stone has unusual shape, like barrel shape. Anatomical factors, mainly tortuous bile duct, periampullary diverticulum, and of course, not to forget the surgical altered anatomy. So, how to create an exit path? The 3 most common ways is either to perform a sphincterotomy, or to perform a sphincteroplasty using a balloon, or to do a sphincterotomy and a sphincteroplasty. We'll be talking about all these techniques, and we'll talk about the difference between those techniques and which one is more effective than the other. So how to perform a sphincterotomy? Usually the question is, first of all, you need to know how to perform the sphincterotomy. Then you need to know how far can we go? How far should I cut? And then you usually cut toward the roof of the papilla between 11 and 13 o'clock. And then you go all the way in the intraduodenal portion of the bile duct to the duodenal wall. You have to be careful because sometimes it's very difficult to know exactly where is the bile duct, but you can see here, this is the papilla, and you can go all the way up actually, but make sure that not to cut the duodenal wall because you're going to end up with a perforation. This can be very tricky, like I said, especially if you have a small flat papilla, but this you have to use your clinical judgment. So the second technique to use an exit path is the endoscopic balloon dilation. So the 2 questions will come in mind: what size of balloon you should start with, and how long should you inflate the balloon, and which is better and safer, to do endoscopic sphincterotomy, endoscopic sphincteroplasty, or to do endoscopic sphincterotomy and endoscopic sphincteroplasty. So all these techniques have been studied. There is a multiple publication about that. When I was a fellow 10 years ago, we used to say, let's start with a 10 millimeter balloon dilation, and then upsize it according to the duct size. But there was a study published in Japan where they did the manometry before balloon dilation and did the manometry after balloon dilation. And they found that if you want to preserve the sphincter and to prevent the biliary reflux, it's better to inflate the balloon up to 8 millimeter rather than 10 millimeter. And then you can upsize this according to your clinical judgment and the need. Mainly sphincteroplasty is being preserved for patients who are coagulopathic because it has less risk of bleeding, but the problem is like it has more risk of developing pancreatitis, and mainly because you don't separate the bile duct from the pancreatic duct, and this is the main concern for us. Usually, like I mentioned earlier, the risk of post-ERCP pancreatitis in most centers is less than 5%. But when you do a sphincteroplasty, if you look at the studies, it's up to 19%, which is a high complication rate. So the other question is, should we do a biliary sphincterotomy, or should we do a balloon dilation? So this is a systematic review of. This is a systematic review of seven studies, and the primary outcome here was the technical success, which is clearing the bile duct from the first session rather than bringing them in multiple sessions. And you can see here this study showed that endoscopic balloon dilation is slightly less successful than endoscopic sphincterotomy in stone extraction, and more riskier for developing pancreatitis, but it is more reserved for patients who are coagulopathic. In general, when you look at the studies comparing biliary sphincterotomy with biliary balloon dilation alone, you will find that if for small stones, they're equally effective. But if you take all comers and all sizes, especially the large stone, then biliary sphincterotomy is slightly more effective than balloon dilation. And the second thing is that you usually will require more mechanical lithotripsy if you use a balloon dilation for stone removal. So Then the next technique of creating an exit bath is that should you do a sphincterotomy or should you do a sphincterotomy with a balloon dilation? And if you have to inflate the balloon, how long you should inflate the balloon? So 20 seconds, 30 seconds, or 60 seconds. So there is at least 2 randomized control trials which has been performed in 2 different countries, and they compared 20 seconds with 60 seconds, and they compared 20 seconds with 30 seconds with 60 seconds, and there was no difference. So basically, whether you inflate the balloon for 20 seconds, 30 seconds, 60 seconds, you will have the same outcome. So this is a study, this is a meta-analysis which show that they compare the balloon dilation with sphincterotomy and the sphincterotomy alone. And what they found that there was an overall clearance, it was statistically significant. The overall clearance and the first procedure clearance was higher in the group who had the sphincterotomy and the balloon dilation than the group who had the sphincterotomy alone. So the next step is that you need to decide whether you need to use the lithotripsy. And if you need to use the lithotripsy, for which cases you should use the lithotripsy and what kind of lithotripsy you should use. So when to use the lithotripsy, if you look at these images, look at those stones, large stones back to back, and they have 2 stones back to back, and then it look like here it's very tight to come out. So if you have large stone, you have a stricture distal to the stone, or you have impacted stones, then you should think about using a lithotripsy. And when you use the lithotripsy, there is 2 types of lithotripsy. There is the mechanical lithotripsy, and then there is the laser and the hydraulic lithotripsy, which we use the spyglass to use those type of lithotripsy. So the equipment, you should decide which type of lithotripsy based on the availability of your equipment, but also based on your expertise. So the mechanical lithotripsy, this was first performed in Germany by a physician named Raymond in 1982, and he basically used the mechanical lithotripsy to remove the stones. Usually the biggest challenge is to get the stone inside the basket and then crush the basket. The success rate usually, it's depending on which study you look at and the size of the stone, it's usually between 85 and 92%. But the problem is that there is a lot of mechanical complication from using this mechanical lithotripsy, and that usually about 30% of patients will need a repeated procedure. So this is a multi-center study where they looked at the complication of lithotripsy. Usually it is the basket entrapment or fracture of the basket, and sometimes it's really difficult to deal with those. And what they found here is that when they use it for the biliary stones, it's about 3.6%, and when they use it for pancreatic stones, it was around 11.6%. So definitely there is some technical challenges here. So then this will bring us up to the next type of lithotripsy, which is the laser and the hydraulic lithotripsy. We usually use the spyglass for those. This is very effective and safe. The success rate is usually around up to 97%. But you have to make sure that you have the equipment, and you have to make sure that you have the skills to use this equipment. And we're going to go back to one of our earlier slides about how to approach, and we are going to talk about assessing the bile duct anatomy in more details. So this is a study where they were looking at anatomical factors which affect or which can cause the removal of the bile duct stone more difficult. And this study was performed by Dr. Hong in South Korea. And what he was looking at, actually the angle, the distal CBD angulation, and he was looking at the length of the distal CBD arm. And what they found here in their multivariate analysis, they found that The distal CBD arm less than 36 millimeter, or the distal CBD angle less than or equal to 135 degree, both of them were an independent risk factor for difficult bile duct stone removal. Then the next challenging category is the one with the surgical anatomy. And this is why you need to review your images ahead of time and take time to plan your procedure. So does the patient have a normal anatomy or not? So when you look at the normal anatomy here, you can see this is normal anatomy, very easy to access. Birrath 1 usually is easy to access. When you go to Birrath 2, this is get more complicated here because you have to go and fish for your papilla. And then when you go to the Roux-en-Y with the gastric bypass, then it gets even more complicated. So how should you approach those patients, and what do you need to prepare for? So there is different ways of dealing with this kind of bile duct stone. It's very important to make sure that either you can use a pediatric colonoscope or an enteroscope, because those are longer than the ERCP scope, and you can access the papilla more successfully. The second thing you need to consider is having a long sphincter tome, like a cotton tome or a Birrath 2 tome, and you need a long wire. So to make sure that you can, when you reach the stone, you can actually cannulate the duct and then remove that stone. I'm going to talk in more details about the Roux-en-Y. Roux-en-Y, there is two more techniques which you can use. The first technique is the edge, which we call endoscopic ultrasound directed transgastric ERCP, or laparoscopic assisted ERCP. Which technique you're going to use is going to depend on your skills and depends on the kind of support that you have. So when you want to access a Birrath, when you want to access Roux-en-Y, if you use the balloon scope, then you need to find the first anastomosis, the second anastomosis, and then you go all the way up and find the papilla and access the duct. Those are the cotton and the Birrath 2 tomes. It's very important to recognize your anatomy is upside down, which means this time you're not going to cut between 11 and 1. You're going to cut at 5 o'clock. The main issue with this, it can be time-consuming, and the success rate is less than the edge procedure and the laparoscopic assisted ERCP. The edge procedure is basically if you have the expertise to perform endoscopic ultrasound, you place an axiostat between the stomach pouch and the excluded stomach. And usually we use the 20 millimeter axios, and then you basically go through the axios and go to the excluded stomach, and then find the papilla and perform your procedure. The advantage of this procedure, when they looked at this one and the surgical assisted, this is more quicker, and the success rate between the edge procedure and the laparoscopic assisted ERCP were similar. The laparoscopic assisted ERCP, usually if the patient's going to go for a cholecystectomy anyway, you can ask your surgeon to give you an access to the excluded stomach using a gastrostomy port, which is usually you ask them for a gastrostomy port between 15 millimeter to 20 millimeter, but make sure it has a balloon inside so it can keep the port will stay fixed and your scope will not be moving in and out, because that can be difficult and sometimes you will find yourself in the peritoneum. So the success rate, when you look at the studies, are similar, but this is more time consuming than doing the edge procedure. So the take home points here, we have number one, up to 15% of bile duct stones are complicated bile duct stones. Minimize the cost to diagnose your bile duct stone by using the ASGE published guideline. Always know your anatomy ahead of time before scheduling your procedure. If possible, use endoscopic biliary sphincterotomy with endoscopic biliary dilation to create a path to remove those complicated bile duct stone. And the final take-home point, if you cannot clear the duct, it is okay. You can just put a stent and then arrange for a second session. Thank you very much.